It's my great pleasure to welcome you to this special session on the occasion of World Alzheimer's Day. First of all, I wish all of you and your families good health during this challenging time. And of course, given the vulnerability of the elderly to COVID, it has never been more important to accelerate the search for a cure. And the two speakers we have today have been at the forefront of this effort. First, a few housekeeping notes. We have a great turnout and we are expecting more people to log in the next 4 to 5 minutes. The first speaker will begin at 12 noon sharp Eastern Time. We have muted all attendee lines. The chat function is enabled and feel free to send us questions or messages on the chat function. The chat function will also be open and we will have the Q&A. It'll go on until 1:30 p.m. Eastern Time for those of you who wish to stay on. But those of you who need to leave by 1 p.m. Eastern Time, feel free to do so. This session is going to be recorded and it's going to be posted on a YouTube channel. And the link for the YouTube channel has been posted in the chat function. Today's session is made possible by a gift from the Karen L. Wrenn Trust and the visionary support of Marjorie Thomas. Marjorie Thomas is a distinguished alumna of the Duke Women's College and the CEO at Ivanhoe Broadcast News. I would like to express our deepest thanks for her support of the Department of Psychiatry at Duke and Duke University for Alzheimer's research. It is now my great pleasure and honor to introduce our two distinguished speakers. The first speaker will be Dr. Eliezer Maslia, who is Director of the Division of Neuroscience at the National Institute of Aging. Dr. Maslia is an internationally renowned neuroscientist in neuropathology. As Director of the NIA's Division of Neuroscience, he oversees the world's largest research program on Alzheimer's disease-related dementias and cognitive aging. Prior to joining the NIH, as head of the University of California, San Diego's experimental neuropathology lab, his lab pioneered novel animal models, as well as new gene therapies, small molecules, and experimental immunotherapies for neurodegenerative disorders. The second speaker would be Professor Kaj Blennow, MD, PhD, professor at the University of Gothenburg, Sweden. Professor Blennow is a pioneer in the development of blood-based biomarkers for Alzheimer's, Parkinson's, ALS, TBI, MCI, and post-surgical cognitive decline. He is dual certified in psychiatry and clinical chemistry. He has published more than 1,200 original research papers and was the recipient of the Henry Wisniewski Lifetime Achievement Award in Alzheimer's disease research. And more importantly, his research on developing an accurate blood test for Alzheimer's was featured in worldwide media, including the New York Times this summer. So it is a great pleasure and honor, and I'm going to now turn over the screen to Dr. Maslia for his introductory comments.
All right, thank you very much, Murali, for that kind introduction and for the invitation. It's really great to be with all of you today. And what I'll do is just give you a little bit of an introduction of our approach to Alzheimer's disease and dementias at the National Institute on Aging and at the NIH. So if I can have the first slide, please. So as is the case, I don't know if, okay, here we go. So the next one, please. So as is the case with many nations in the world, the US has a national plan to address Alzheimer's disease. This plan was signed into law in 2011 by Congress and at the time President Obama into what is now called NAPA, or National Alzheimer Project Act. And NAPA has at its main goal or primary goal to come up with a treatment or a preventive therapy for Alzheimer's disease by the year 2025. So that's very close, I mean, just a few years ahead. And the interesting thing about the plan is that it's not only including Alzheimer's disease, but also other related dementias, including dementia with Lewy body, frontotemporal dementia, and vascular dementia, as well as the mixed forms of dementia. As we know, many of these neurodegenerative disorders overlap. With this national plan has come significant increases in funding for AD and ADRD research. In 2016, when I joined NIA, our level of funding for this kind of research was around 500 to 600 million a year. And now by the year 2019 grew to 2.4 billion. And on the next slide, please. For the year 2020, we receive an additional 350 million for AD and ADRD research, for a total of 2.8 billion, almost 3 billion now for this sort of research, which is really quite exciting and important. However, as you can see on the graph published in Science, although funding for AD-ADRD research at NIH has been increasing considerably over the last couple of years, we're still way behind compared to where funding levels are for other disorders where there is some therapeutics available now, like HIV/AIDS and cancer, where increases in funding have been going on for decades already. So we still have a long way to go, but definitely in a very exciting and important trajectory. And then the next slide, please. For the year 2021, we still don't have a bill, as you know. The Senate has no draft bills. The House has a draft bill, which is mostly focusing on COVID-19. This bill includes a 5.5 billion increase, primarily, as I said, for COVID-19 research. And there is a 35 million component targeted for AD-ADRD for NIA, in addition to the funding for COVID. But none of these has been really further discussed or approved. And federal government currently is to be funded until September 30th. After that, we expect that probably we'll have a CR, but that remains to be seen. So the national plan has really 5 cornerstones, and these cornerstones have been developed together with the community through summits, workshops, and a number of other events. And what we've been focusing these last few years of the national plan is on creating a greater integration between basic, preclinical, and clinical programs, so we can get to therapeutics faster than what we used to do before. As it will be the topic for today's symposium, early detection and diagnosis is absolutely key, primarily through biomarkers and the creation of a research framework for biomarkers. And then, of course, for developing therapeutics and developing diagnostic tools, we need to be able to recruit large numbers of people for these sort of clinical studies. So we also have a national strategy to enhance recruitment for AD clinical studies, biomarker studies, longitudinal studies. And finally, we absolutely need more clinical trials. We need to enhance the clinical trial pipeline with what we call more shots on goal. And the next one, please. In these last few years, the national plan has had many areas of success. We have expanded our translational programs with multidisciplinary approaches. We have enhanced our basic studies with expansion, particularly on the genetics, where a number of new genes on the endosomal, lysosomal pathways, inflammatory, lipid metabolism, etc., have now been discovered. We also, thanks to AMP-AD, have expanded the number of potential therapeutic targets for AD to almost 500, and all of these data and these targets are made publicly available to the Agora website. We're funding over 230 clinical trials that include both pharmacological and non-pharmacological, both prevention and treatment. And we're also in other less traditional areas, for example, on caregivers, our care partners. And then, of course, I would say one of the jewel of the progress in the last few years have been the discovery and development of novel biomarkers, including imaging and blood tests. And we're going to be hearing a lot more about that from Dr. Bleno later on. But this has been obviously one of the greatest accomplishments, not only of national planning in the US, but efforts throughout the world, including in Europe. On the next one, please. And in this particular area, NIA has been collaborating with the Alzheimer's Association and with the field in general, with including Dr. Bleno and many others, creating what we called a research framework for biomarkers for Alzheimer's disease. And we'll probably hear more about it, this so-called ATN system, which primarily focuses on A for amyloid, T for tau, and N for neurodegeneration. But we also think that we need to develop biomarkers for a number of other processes going on in Alzheimer's disease, including alterations in synapses, vascular alterations, accumulation of other proteins like synuclein and TDP-43, inflammatory processes, and also aging, which is something that we don't think traditionally in terms of biomarkers, but it's something that I think would be important to think about in the future. And in the next slide, please. As I was mentioning, we know that the neurodegenerative process in AD and related dementias, sure, in the one hand, it's part of the consequences of the proteomyopathy, including the deposition of A beta, tau, synuclein, and other proteins leading to synapse damage and neurodegeneration. But of course, aging is a major risk factor for these dementias, and processes such as alterations in proteostasis, mitochondria, inflammation, stem cell, vascular factors, DNA damage, cell senescence, and immune surveillance are important. And biomarkers for all these processes that actually have the advantage that could also be detected in the periphery are currently being thought of and developed. I mean, the idea, for example, of telomerase length is something that has been around for a while, and other measurements of DNA damage, but also biomarkers of peripheral biomarkers of cell senescence, quite important. And I think combining biomarkers on the ATN system, as we have mentioned before, with discovery of other types of biomarkers along the aging pathway and combining them, I think would also be very important. And then finally, we also have biomarkers on environmental factors. I know we've heard in the last few years about potential infectious disorders, and now on the COVID-19 era, we need to think more about the contribution of viruses and other pathogens to dementia, but also other environmental factors like contamination and so on. So I think it'd be important to think about biomarkers in a multidisciplinary way, and we're gonna learn and hear more about it from Kash in a few minutes. So my last slide, please. Just again, want to thank for your attention, and just remind you of our website and our funding opportunities in all these different areas that I mentioned. And thank you very much again.
Thank you, Dr. Maslia. That was excellent. And first of all, thank you for your support. I think the field is indebted to NIA and you and others such as your organization. It's my great pleasure now to invite Kaj to give his lecture.
Thank you so much. I will see if I can share the screen. Is it okay there?
No, we can't see your screen yet, Kash.
I'll see what I can do.
Can you try now again?
Share screen. And there it should be. Share.
Yeah, it's like it's.
Now it's working. So thank you so much, Murali, for inviting me to give this lecture. It's a great honor for me to do it, and not the least also on September 21, the Alzheimer's Day, which is really important, I think. So I will give a presentation on blood biomarkers for AD. I will have a few slides on cerebrospinal fluid because that's how the whole story started more than 2 decades ago. So this is a neuron with a smaller astrocyte, and to the right you have the synapses, and I fully agree with Dr. Massilia that we need also synaptic biomarkers and also for many other processes involved in AD, but these are the so-called core biomarkers for AD, starting with beta amyloid. Both the 42 amino acid and the 40 amino acid isoform is used as biomarkers. They reflect A-beta aggregation and deposition into plaques in Alzheimer's disease. Then we have phosphorylated tau related to the development of tangles, and then total tau, the same protein but without phosphorylation, that reflects neuronal degeneration. And finally, another marker is neurofilament light, NFL, which is a more general and disease unspecific biomarker for axonal degeneration. So this is a summary slide on many different CSF studies. This is a systematic review and meta-analysis published a few years ago. And it summarizes all the papers published from the start in 1995. So here we have total tau, which reflects the intensity of neurodegeneration in AD. There's a 250% increase compared to age-matched healthy people, and quite a number of studies and many patients and controls examined, and all actually show the same thing, this increase in AD. For A-beta 42, it's instead a reduction because it's believed that A-beta 42 is deposited in the plaques with less amounts left to diffuse out to the cerebrospinal fluid. Also quite a number of very consistent results in all of these papers. Finally, phospho-tau, there's a roughly 200% increase in AD reflecting the phosphorylation state and tau pathology, and also very consistent results. But these figures are on AD dementia, and how about early AD? You can also review all of these studies at the ALZ forum in the ALZ biomarker database, and this year there will also be data for differential diagnosis, then I mean FTD, Lewy body disease, and so forth. So this is a few early studies on prodromal AD. The Hanson study published in 2006 in Lancet Neurology included more than 200 patients and controls, patients with MCI, and they were followed clinically for more than 6-7 years. And to sum up, the combination of tau, A-beta, and phospho-tau in cerebrospinal fluid could identify 95% of the progressive cases, meaning that they had AD pathology from start, compared to even 87% specificity for stable MCI and MCI cases developing other dementias. And this type of data has been replicated in quite a number of studies, very large multi-center cohorts, for example, the DISCREPA study in Europe, the ADNI study in the US, and a project called the Swedish biomarker study that also included many clinical centers from different countries. So it's quite clear that the AD-CSF biomarkers also work in the MCI stage of the disease, where the patients have very mild symptoms but are very difficult to diagnose. So what is needed to get the CSF biomarkers into the clinic? This is something the International Federation of Clinical Chemistry Working Group has been working on. So first of all, you need a gold standard method, also called a reference measurement procedure, that we have for many different biomarkers in clinical chemistry, and since 2014 also for A-beta in cerebrospinal fluid. And this type of techniques have also been approved by the JCTLM, which is the Joint Committee for Traceability in Laboratory Medicine. And why do you need a reference measurement procedure? This is to set the levels on reference material. So this is aliquots, quite a high number of aliquots, meaning thousands of large CSF pools with different levels of A-beta 42 in this case, that have been value assigned using the reference measurement procedures, and these are used to harmonize levels across different assay platforms and also longitudinally in big laboratories running these assays in clinical routine or in clinical trials. Finally, the best thing is to have high precision methods. From start it was ELISA methods, but today we have fully automated and high precision methods, for example the Cobas Elixis by Roche and the Lumipulse by Fujifilm Bio. This is a laboratory analysis with no manual steps, and they have shown superior performance in the real-life situation with very low between laboratory CVs. So we have what is needed to introduce these methods into clinical routine, and this is today done in many countries. So patients are evaluated by CSF tests. So if you compare the CSF biomarkers to other diagnostic tools, for example, amyloid PET, how does it work? This is a large study on both a biofinder cohort from Sweden and the ADNI study comparing CSF biomarkers, A-beta, tau, and phospho-tau with amyloid PET. And the amyloid PET was evaluated by 3 different expert readers with a visual read into either positive and or negative. And here you see the concordance between CSF tests and visual amyloid PET. So both phospho-tau and total tau2 A-beta ratios had an overall percentage agreement of around 90%. So not 100% for sure, but at the same time, the inter-rater PET agreement was also 90% for decommising the scans into either positive or negative. So maybe this is as high as you can come, and it suggests that the CSF biomarkers and amyloid PET scans can be used interchangeably. So we have both amyloid and tau PET and also the CSF tests, but how will this work in the future? I think the day we have approved drugs with disease-modifying effects, for example, aducanumab and others are on the way, also in phase 3 trials, for example, BAN2401 by Eisai. We need additional biomarkers because PET scans are expensive and have limited availability, so limited free times and limited number of PET centers and lumbar punctures may be difficult to introduce on a large scale basis. So I think we need blood tests for amyloid tau and neurodegeneration type of pathophysiology for large scale assessment of AD risk. And how can you use blood biomarkers then? Yeah, first of all, of course, for diagnostics, or even better, maybe screening, to select true AD cases for inclusion in the trials, and also make in the future a correct diagnosis for initiation of treatment of a new disease-modifying drugs. You can also use blood biomarkers in trials. One is to identify and monitor target engagement, meaning that it will, for example, affect beta amyloid metabolism or tau secretion, drugs targeting these two pathophysiologies, but also to identify downstream effect of a drug. For example, if you have an A-beta immunity, it would be important to show that the treatment leads to reduced intensity of neurodegeneration by monitoring, for example, tau and the neurofilament light. Finally, I think they are also very important in research where it has been difficult to implement the PET scans or CSF tests, and then I mean especially in both genetic and environmental research, epidemiological studies to identify risk factors or risk genes for specific AD pathophysiology, A, T, and N, and not only then for old age dementia. So plasma A-beta, that has been studied for a number of years using ELISA tests, and this is how it looked from start. This is also from the Alzheimer biomarker database. So to the left, A-beta 42 in plasma, and to the right, A-beta 40, and the line falling 1, meaning no change. So you see that these results were not very promising at all based on ELISA methods, also suggesting that we need some other type of techniques. And this has been developed today. So one technique is called SIMOA, or single molecule array, and the A-beta method was published in 2011. So SIMOA is a bead-based immunoassay where you have magnetic beads coated with antibodies, and then immunoreaction takes place on the surface of the beads, and then in the end, to make a long story short, you have a digital quantification of positive beads that have captured A-beta divided by negative beads. And this improves the analytical sensitivity quite a bit, almost 500 to 1,000 times in many cases. The other example of new technologies is mass spectrometry, or immunoprecipitation combined with mass spectrometry. So this is a paper from 2014 on IP MALDI, or IP mass spec, single reaction monitoring methods for plasma A-beta, and this is just a short extract of the results in this paper. This is the plasma A-beta profile in plasma. And it's very similar to that in CSF. So you have a large A-beta 1 to 40 peak, a small 42 peak, and then you have a number of other less abundant A-beta isoform, but 42 and 40 are the important ones. And if you analyze these by these new ultra-sensitive SIMOA assays, how does it look? This is one example. This is the biofinder study, large cohort with controls, subjective cognitive decline, mild cognitive impairment, and AD dementia cases. And a good thing was that suddenly you can see a correlation between plasma and CSF, A-beta 42 to 40 ratio, not very strong, but still significant. You can also see a relation between SUVRs on amyloid PET and the plasma ratio of A-beta 42. And you can see a small drop in the ratio in AD dementia cases and also in MCI cases. It's not very marked, but it is significant. And this has also been evaluated in much larger studies using immunoprecipitation and mass spectrometry. So this is the Bateman paper from 2017. And here a mid-domain antibody was used, and after digestion of A-beta with lys-N, a protease, and firm orbit trap mass spec, the data looks like this. So there's a clear drop in the ratio, suggests in amyloid positive cases, and a very high AUC value of 0.89. So very promising results, but again, the drop is not very marked. It's 14% lower than in amyloid negative cases. This is a very large study also by the Nakamura group and also Colin Masters group in Australia. So they used instead Marditov mass spec and a mid-domain A-beta antibody 6E10, and except for A-beta 40 and 42, they also measured a bit N-terminally extended A-beta variant. You can call it A-beta -3 to 40, or you could call it APP 669 to 711, which is the same. And here you see the results. So they express the data in the opposite way, so not the 42 to 40 ratio, instead of the 40 to 42 ratio, and also this APP to 42 ratio, and then the combined composite biomarkers of both. And results are very promising, and the AUC values are very high, again supporting that plasma A-beta could work as a biomarker to identify brain amyloidosis. This is a more recent study in neurology, also by Randy Bateman's group. And a good thing here was that the plasma and CSF A-beta 42 to 40 ratio was compared in the same patients and in using the same method. And to the left you see plasma results, and to the right you see CSF results for the ratio, and both are significantly down, and the AUC values are quite high, but as you see again, the drop in plasma is really not that clear. There's a 10% reduction in plasma compared to a 43% reduction in cerebrospinal fluid, meaning also a greater overlap, of course, but still very promising results that plasma A-beta will work as a marker for brain amyloid. How about total tau? Total tau is a very good Alzheimer biomarker in cerebrospinal fluid. This is plasma tau using the Simoa assay. Here you have controls, MCI cases and AD cases. There's a slight increase in AD, but not really very much, and a big overlap. And the explanation you see here. So using this type of Simoa assays, there's really no correlation between plasma and CSF levels of total tau. And this type of data was also validated in the large ADNI cohort on controls, MCI and AD cases. As you see here, there's a slight increase in AD dementia, not in MCI, and a very large overlap. So I think we need to make more efforts to develop the total tau assay in blood further to get it to work as an Alzheimer's disease biomarker. And important thing to say here, even if I, due to the limited time, don't have any slides on this, is that total tau works really well as a biomarker for acute brain damage, for example, in traumatic brain injury or hypoxic brain injury related to cardiac arrest, but not in AD then. How about plasma phosphorylated tau? Could that work? This is the first study on plasma phospho-tau published by a Japanese group in 2017. So they used the Quanterix Simoa total tau assay, and then they changed one antibody to a phospho-tau 181 antibody and evaluated this new assay in a small cohort of 15 controls and 20 AD dementia cases. But results were very interesting and promising. So there was a clear increase in plasma phospho-tau 181 in blood, as you can see here, and several of the control samples and even some AD samples couldn't be measured, but still there was a very clear change in AD. And a good thing was also that the correlation between plasma levels and CSF levels of phospho-tau was very tight. So this was very supportive that it will be possible to develop a blood biomarker test for phosphorylated tau. And then in 2018 came this study. This is a method, an mesoscale or MSD method developed by Jeff Dage at Lilly Research Lab in the US and evaluated on the Mayo cohort by Michel Mielke and Ronald Peterson. So quite a large cohort with cognitively unimpaired people, MCI cases and AD dementia, and also stratification by amyloid PET scans into amyloid negative and positive. And as you see here, there's a clear increase in AD dementia and also in amyloid positive MCI cases with a high AUC value of 0.80. Just for comparison here of total tau data from the same study, very similar to what I showed previously. So total tau shows only minor change in AD, but phospho-tau looks very promising also using this new MSD assay. And then this year came two large studies published in Nature Medicine, one based on the Adam Boxer cohort in San Francisco. And here you see the results for healthy controls to the left. They have low levels of phospho-tau 181, but in AD they are clearly up, quite a clear increase. But the good thing was that phospho-tau was normally quite a number of other disorders, for example, PSP, FTD, CBS, and so forth. And in the same issue of this journal, there came another paper based on the Biofinder cohort in Sweden, and this is just a little short extract of the data, the correlation between plasma phospho-tau 181 levels and Braak stages evaluated by tau PET. So tau PET negative cases, they have really low levels, and then they go up with increasing spread and amount of tau pathology in the brain. So again, very promising data for phospho-tau as a biomarker for AD and AD-type tau pathology. We also worked with phospho-tau in blood, and we used the Simoa method instead and managed to develop an phospho-tau 181 assay. We started with a small discovery cohort. So here you see both plasma to the left and serum to the right, phospho-tau 181 levels in AD compared to A-beta negative older adults. Here you see the AUC values reaching quite high in this small cohort. And the good thing also here is that there was a tight correlation between blood and CSF levels of phospho-tau 181, supporting that this biomarker reflects brain pathophysiology. But in two larger validation studies in the same paper, this is the triad cohort from Montreal, Pedro Rosaneto and colleagues. Here you see the results for AD, A beta positive MCI cases, and a number of other groups, including FTD. And here you have the AUC values. So the performance is very high, 100% AUC for differentiation between AD and FTD, and very high also for older and adults and A beta negative MCI cases. And this is the biomarker data in the same paper, very similar. And also here you see that the phospho-tau levels are normal in a number of other neurodegenerative disorders, including, for example, PD and PSP, and also vascular dementia with quite high AUC values for the differentiation from AD cases. So some more data. This is an independent validation study on serum. In this case, phospho-tau 181, it works equally well with either serum or plasma. So this is an Italian cohort by Barbara Baroni. So it's 291 cases, quite a number of FTLD spectrum patients and also clinical AD and healthy controls. And again, there's a specific increase in phospho-tau 181 in AD cases, but normal in all of the other brain disorders, and the AUC values for the differentiation between FTLD and AD was as high as 93%. So again, supporting phospho-tau as an Alzheimer biomarker. How about the very early phase of AD? This is from the Lancet Neurology paper again, and here you see results from cognitively unimpaired individuals who have a negative tau PET scan, but some of them already have a positive amyloid PET scan. And you see that in the amyloid positive but still tau PET negative cases, there's an increase in phospho-tau 181 in blood with an AUC value of 84–85%, suggesting that phospho-tau is increased very early, maybe even before tau PET becomes positive. And this type of data has been examined also in other studies. This is together with a group in London, Nick Fox and colleagues on their FAD cohort at UCL. So this is symptomatic FAD patients, asymptomatic mutation carriers, and also non-carrier members of the same family, and Simoa 181 in blood. And here you see that there's a very clear increase in symptomatic cases, but also already in pre-symptomatic FAD with quite high AUC values, not 0.93 for symptomatic and 0.86 for asymptomatic cases. And the mean here was 7 years before expected year of onset. And here you see the curves, and they start to diverge something like 16 years before expected year of onset at the group level. Then you see that the phospho-tau 181 starts to increase. Later this year came this study. This is again the Jeff Dage group at Lilly who developed a phospho-tau 217 assay, again based on the MSD platform, and I can only show you an extract of the results. So this is a quite busy summary table of all the comparisons across different diseases. So it's AD dementia compared to a number of other groups, so A beta negative neurodegenerative diseases and so forth, Parkinson and vascular dementia. But overall, the AUC to differentiate AD from other groups is very, very high, 0.96, which is remarkable, I think. So very promising results. So now we have a number of different phospho-tau assays. So how do they compare? I think that will be something for the future to examine in more detail. So this is comparing two studies. I think it's needed that you compare the assays of the biomarkers in the same study, but this is the phospho-tau 217 assay compared to neuropathological results. So here you see that in AD, phospho-tau 217 correlates with the tangle density score, and the AUC to differentiate AD at neuropathology from non-AD is quite high, 0.89. And this is another cohort. This is a neuropathology cohort from United Kingdom, and plasma samples were taken 8, 4, and 2 years before death, and results are very similar throughout. So already 8 years before death, the AUC values to differentiate AD from non-AD was as high as 0.97, I'm sorry. But again, I think we need to compare these biomarkers in the same cohort and with as similar assays as possible. This is still a new phospho-tau biomarker in blood. So this is 231. And some years ago, there were CSF papers on phospho-tau 231 that showed very promising results. But this is 231 assay we just have developed here in Gothenburg. This is a very small cohort, but there's a clear increase in AD, a bit better in this specific analysis than phospho-tau 181. But we have continued with larger cohorts, and phospho-tau 231 looks very promising. So it looks like a very early biomarker in AD, maybe even earlier than phospho-tau 181. There are currently no studies comparing all of phospho-tau 181, 217, and 231 in blood directly, but this is a CSF study. So this is our assays for 181, 217, and 231 in cerebrospinal fluid, and patients divided into amyloid and tau negative, amyloid and tau positive, and then A plus T minus or A minus T plus. And you see that in the A plus T plus groups, there's a clear increase in all three biomarkers compared to the other groups. Here you see something interesting, and this is the correlations between the different phospho-tau biomarkers. So to the left, 181 versus 217, and then 181 versus 231, and to the right, 217 versus 231. And you see that the correlations are very tight, so they are around 0.9. And to me, this tells that they perform very similarly, and maybe that the differences across them will not be that large. But we have to evaluate that in a number of future studies. I will end with a bit on neurofilament light. So neurofilament light has been examined in CSF since many years, and it's an axonal protein. It's part of a neurofilament triplet, and it's important for growth and stability of the axons in the brain. And it's believed that with neuronal or axonal injury, neurofilament proteins will be released into the cerebrospinal fluid and also into the blood. This is the Simoa assay, the first study on measurement of NFL in blood. And as I said, there was an ELISA for CSF, and this is a comparison of analytical sensitivity of a new CMOA method compared to ELISA, and as expected, the CMOA was much more sensitive, meaning that it's possible to measure NFL in blood. And a good thing in this study, and this has been validated in quite a number of other studies, is that the correlation between blood and CSF levels of neurofilament light is very tight, also supporting that it reflects axonal degeneration and damage in the brain. So here is a study on the ADNI cohort, again, neurofilament light in plasma. Here you see the AUC values. So plasma NFL, you can come up to 0.87, and this is the same, or in the same range as, for example, CSF measures of A beta and tau, and also CSF NFL, since they correlate so tightly. And this is just a little bit more data from this paper showing that plasma NFL levels predict future rate of cognitive decline. This is in MCI patients. How about the NFL as an early AD biomarker? This is again the London group on FAD, so different groups, symptomatic FAD, pre-symptomatic carriers and non-mutation carriers. And here you see similar data that the increase in serum NFL starts before the expected year of onset. And this is some years later from the Diane study, much larger study, and both CSF and serum data. So CSF to the left and the blood to the right, and you see again that the NFL starts to increase before the expected year of onset, around maybe 7 years before, so supporting that NFL is also a very early biomarker for neuronal degeneration in AD. So this is just a summary slide. So there are quite an amount of data supporting that plasma biomarkers for amyloid, tau, and neurodegeneration will be useful as screening tools in the first assessment of patients with cognitive symptoms. We have to see if they work also as diagnostic tools, but they surely could have a value as screening tools, and the results may guide further clinical management. So normal values would indicate no further examinations needed, and abnormal values, then the patient could have admission form to the specialist clinic where a more detailed diagnostic evaluation could be done using what could be called the second grade biomarkers, CSF tests, PET scans, amyloid and tau, and of course MRI scans. And we need to see this. There are data at least showing that the biomarker levels in blood are quite stable over the time length of a typical AD trial, but we need to wait the data until we have an approved disease-modifying drug to show that these type of biomarkers can also be useful to monitor drug effects on amyloid and tau and neurodegeneration type of pathophysiology in AD. Thank you so much.
Kaj, thank you so much. That was brilliant and very hopeful and extremely informative. And if both yourself and Dr. Eliza would like to stay on the line, I would like to invite people from the audience to type in any questions they may have in the chat function. We already have one question from the audience, which is, what is the intra-individual variability of p-tau and NFL?
So p-tau, this is on the way to be published from the ADNI study. So if you look over a time window of 2 years. So the intra-individual CVs are in the range of 7%, 7 to 10 maybe. So to me, quite low. Also considering that this is immune assays, and it's a combination of assay variability and biological variability that ends up with below 10% CVs. So quite good, I would say.
Dr.
I wonder if Kash could comment regarding diverse populations. I mean, we know that a lot of these studies have been done in ADNI or European populations or European descent, and we have relatively low data on Hispanics, Asians, and other African Americans. But I don't know if Kash has some update on that regard, and how translatable or reproducible are the results in plasma in diverse populations?
Yeah, that's a very important question. Thank you. I would say there are not too many studies on this. The one I can think of is from the Colombian kindred with FAD. And there are data published on neurofilament light, and that the results are very similar to those from Diane. So there's a clear and significant increase a number of years before the expected year of onset. But I believe that we need this type of studies that you proposed, and also studies where these type of biomarkers, but then of course also the other modalities of biomarkers, amyloid PET scans, tau PET scans, MRI measures are evaluated in a clinical setting with prospective unselected patients that can have a very wide diversity of diagnosis, and not this type of specialized clinics or research units with highly selected cases with already existing data with amyloid and tau PET and MRI and everything. That is what we need in the coming years.
Thank you, Kaj. We have one more question, which is, can you please tell us about the optimal biomarkers for FTLD and DLB?
So for FTLD, there is one biomarker that works, and that is neurofilament light, because the increase in both cerebrospinal fluid and plasma NFL is much more clear than in AD. So it can more or less be used to differentiate between these two conditions. But at the same time, NFL is a non-disease specific biomarker. So it's increased also, for example, in ALS, in PSP, in CBD, in MSA, in multiple sclerosis, and many other disorders with neuronal damage. But then I'm not aware of more FTD biomarkers that really work like NFL. For Lewy body dementia, it's also, I mean, there has been studies showing a drop in A beta 42 and the 42 to 40 ratio, but to me, it doesn't look like it's fully diagnostically useful to differentiate from other diseases based on only this. So we need more studies also, as discussed, on these other disorders for sure.
Thank you. One more question, very interesting from the audience. What is the direction of change that has been shown in therapeutic trials? For example, in the aducanumab trial, was there a change from baseline after treatment in NFL levels or in any of the blood-based biomarker levels?
There has been a paucity of biomarker data from these trials, I would say. I haven't seen, I mean, the phase 1 trial was, or 1B trial was published a number of years ago, and still there hasn't been any papers on NFL, for example, or phospho-tau or A beta in plasma. I mean, PTAR was developed this year, so maybe that's too short time, but I haven't seen much. There has been some CSF data shown at congresses and so forth, but quite a little bit too little data shown publicly, I think.
So two interesting questions. Are any of these blood tests ready for clinical approval and use today in the clinic? And what should be the criteria for selecting patients to order these tests?
Yeah, so I would say that differs a bit across countries, the whole procedure for approval. So here in Sweden, for example, it's quite different from United States, and I think it's similar in many European countries. So, for example, all the CSF tests are available for the clinician since many years. So total tau, phospho tau, A-beta 40, 42, neurofilament light, they are used more or less on a routine basis in many countries, for example, Germany, many centers in France, in Sweden, Finland, Norway, and so on. The blood tests are a bit behind, but a number of labs have now also set up neurofilament light as a clinical diagnostic test. It's a disease unspecific, but it's used to either identify or exclude neurodegeneration or neuronal damage. It's used both in the investigation of patients with possible neurodegenerative conditions, but also in acute care. So it's used by intensive care unit doctors, for example, in brain trauma cases and brain hypoxia cases and so forth, and also by child neurologists who have many neurodegenerative disorders in children have high NFL levels.
Thank you, Dr. Elizer. Couple of questions. The NIA is funding a number of biomarker studies, including metabolomics, the microbiome. Where do we stand? Are those tests close to these other tests that were presented today? And what about inflammatory biomarkers? What is the relationship between inflammatory biomarkers? Should we be ordering them as well?
Yeah, those are very important questions. A lot of the multi-omic type of biomarkers, more complex, multi-network type of biomarkers, they are all available publicly through the AMP-AD knowledge portal that is managed by Sage Bionetworks. If you just type AMP-AD Sage, it will take you to there, and you can look at all the data. It includes data from approximately 3,000 cases, many of them already verified neuropathologically. But we also are doing metabolomic and multi-omic type of analysis on a subset of ADNI that is also available through the AMP-AD. And the investigators from AMP-AD have identified a number of modules, many of them pointing toward synaptic proteins, some of them toward inflammatory proteins. And these are, again, multi-network type approaches that could also be used as therapeutic targets. And again, all of that is available publicly. In terms of inflammatory biomarkers, maybe Kash could comment more about it. He knows more than I do, but I mean, there have been a number of efforts using ligands for PET imaging that unfortunately give a lot of non-specific noise, and there has been an effort to improve on those radioligands, and I think still there is a lot of way to go on that, but some progress. And I mean, in terms of plasma, there is quite a bit on cytokines, chemokines, especially TNF, IL-6. That looks pretty good. Again, it's just the question about specificity to AD versus all the neurodegenerative disorders or other inflammatory, chronic or acute, that has always been the question, but maybe Kash could comment more about it.
Yeah, I agree. There are some, except for the cytokines, there are also some glial and microglial proteins that are in some way related to neuroinflammation. And when I refer to estrem2, YKL40, and also glial fibrillary acidic protein, GFAP. So in which way they are related to inflammation, I'm not sure, but there is a change in these biomarkers in AD, and I think they are really interesting proteins and needs further study.
There are two somewhat technical questions. One is, what is the inter-individual variability of NFL? And the second is, do you think the Simoa assays can be transferred to the Roche, Alexis, or the Gujaribio platforms?
Yeah, very good questions. So for NFL, was it the analytical or the inter-individual variability?
I think it's inter-individual is the question, but you could answer both.
Yeah, I mean, the inter-individual variability for NFL is huge. So for example, it maybe not huge, but it increases with the normal aging. That's some type of problem. Maybe you can see it, but if you examine large enough numbers of healthy people of different age, then you can identify cutoffs that seems to work in the clinic. The second question was about transferring these assays to automated platforms, and that is a really good question, and that is actually ongoing by both companies. And there are actually one first paper out there on A beta 42 to 40 ratio on the Alexis system that looks very promising. And I think the AUC there was around 0.80. So it's really magic to make these biomarkers work on this type of instruments, I think. But it's large companies, and they have resources, sources and knowledge to do it. And I'm convinced it will be there in a few years that you can do. NFL, that is also on the way by 3 different companies having this type of large lab instruments, and also phosphatide. So just to wait, and then we have these assays on every clinical chemistry lab around the world.
And this is a question for Dr. Maslia and Kaj. Is there going to be an NIA or other consensus recommendations for when to use blood markers? At what age should we screen for blood markers in people with a positive family history? Where can we go to do the test? Do we order all of these blood tests, or which blood tests do we choose? Is there some plans to provide some guidance for clinicians?
Yeah, no, that's also a very important question. I mean, at the moment, there are no plans for additional recommendations beyond the 2018 framework that I mentioned before, that Cliff, Jack, Kash, and many others put forward. But that certainly, I mean, I think is warranted to look into. I mean, I think that really the bottom line is the validation and testing of the framework in a larger number of samples and diverse populations and across different, different stages of the disease. And the other thing to remember is that we didn't talk much about it, but many of these neurodegenerative disorders, especially in advanced stages, tend to overlap. So, I mean, we might have positive markers for amyloid and tau, but people might also be developing a vascular component or a synucleinopathy or TDP-43 component. So we're missing biomarkers for that. So I think those are the areas that we would like to contemplate before making any kind of stronger suggestion. I think we need to further validate ATN. I mean, I know, of course, if one is looking at autosomal dominant or other types of genetic, very strong genetic influence, well, of course, earlier onset is probably a more straightforward proposal, and that could be looked into. But the greater majority of the case of dementia, I think it's still somewhere to go. But I don't know, Cash, what do you think?
No, I fully agree. I think when you come to these more unselected cohorts, then you will come into the issue with multiple pathologies. So not only plaques and tangles and neurodegeneration, but also, as you said, synuclein, TDP, microvascular changes. And for these, we do not really have validated biomarkers today. And that will introduce problems and clearly something that needs to be worked on.
Kaj, I know we had chatted about neurogranin. I don't think you got into in today's talk. Would you like to share some of your recent research on that?
Yeah, so neurogranin is a dendritic protein, a synaptic protein on the dendritic side. So it's a small protein, only 78 amino acids, and soluble, and is diffusing out to the cerebrospinal fluid. And today there are a number of studies by different groups using different assays that all show a clear increase in AD, also in the very early stages of disease, and higher neurogranin predicts also cognitive decline in the future. And maybe, to me at least, the surprising result was that the increase is more or less only found in Alzheimer's disease. So even if you have synaptic degeneration in quite a number of different disorders, the increase in neurogranin in cerebrospinal fluid is only there in Alzheimer's disease.
So I have another question here from the audience. Many Alzheimer patients show psychiatric comorbidities such as mood disorders, agitation, etc. Is there a relationship between any of these biomarkers and psychiatric comorbidities?
That's an interesting question. And I mean, these biomarkers have also been examined in first of all, patients with only psychiatric conditions, so not combined with AD type of pathology. And if there are any changes, it's really, really minor. So more or less no change. And that's maybe a problem in general with psychiatric conditions, that diagnosis rely on more or less pure clinical grounds and maybe response to treatment combined, but there are no really validated biomarkers for these diseases.
Another related question to both of you. The NIA, of course, has funded metabolomic studies, and one of the findings, it's actually a study led by a Duke investigator showing bile acids are altered in Alzheimer's disease, and many bile acids are related to neurodegenerative changes in the brain. And we also saw in the New England Journal this week a paper looking at TUDCA, which is a bile acid, as a potentially promising treatment for ALS. So again, would love your thoughts on blood-based measurements of bile acids. What do you think is the relationship between the liver, the gut, and the brain? We'll be measuring those.
Can I pass this question to Dr. Maslow?
Yeah, I mean, at Duke, Dr. Rima Kadura has conducted many of those studies, and I think that there is definitely a very tantalizing connection between bile acids, microbiome, and a lot of what we see cognitively in patients with with Alzheimer's disease. A lot of these data is publicly available either through AMP-AD knowledge portal or through ADNI. And of course, the challenge, right, is that there are so many of these different metabolites, and I mean, it's a little bit difficult when you have to measure such a great variety of metabolites, and we have a limited population where to study it to really expand the results to or generalize the results to a larger population, given the limitations. But I mean, certainly there is a very interesting connection there. And again, when thinking about more targeted therapeutics, maybe some of these metabolomic biomarkers that Dr. Rima Kadura have developed might be applicable.
Thank you. One more question. There are many older individuals who have silent pathology in the brain, especially A-beta, and some of these are called preclinical AD. How do their biomarker profiles differ from older individuals who don't have such pathology in the brain?
So maybe I can start. So this was a problem from in the early years of CSF biomarker studies, that you had this type of overlap with cognitively unimpaired elderly, because there was no amyloid PET scans, and when you found that a percentage of cognitively normal elderly people have low A-beta 42 in CSF, then we had really no answer. But the thing that really helped was amyloid PET scans, because then you could divide the healthy group into those who have some amyloid pathology and those who don't. And then you see that the reduction in 42 or the 42 to 40 ratio is there, even if you don't have any symptoms. So that's very clear, I think. And whether then that is, I mean, that is evidence of brain amyloidosis, whether it's something more, for example, preclinical AD, I think we need to understand or study in more detail how many of these individuals will actually develop symptoms, but I do think that they have a pathology.
And do you know at what age, how many years before the onset of sporadic AD will, say, an individual in their 40s or their 50s, or when is the earliest that you're seeing in just a normal older cohort for some of these blood biomarkers to become sort of abnormal, if you will?
I think there is also a need of more studies, but something in the range of 5 to 10 years before the onset of symptoms, you can see the changes. And also, if you, according to the Cliff-Jack curves on the development of AD biomarkers, I think that is correct, that the change in A-beta seems to come first, followed maybe today by phospho-tau and later on neurodegeneration. So following ATN and then symptoms. If you add on synaptic biomarkers there, then it looks like they also come quite early.
Well, thank you very much. We are out of questions, and I want to thank both of our distinguished panelists. I also want to thank the Karen L. Wrenn Trust and Marjorie Thomas for supporting this program, and I want to thank all of the attendees who have participated today. I hope this has been very inspiring, very optimistic, and I'm absolutely delighted to have both of you, and I want to thank everybody for their time.